Kishan, we can start now.
Okay, sir. Hello, good evening. Today's my topic is laser in glaucoma.
Hello, Kishan.
Sir. Hello, good evening. Today's my topic is laser in glaucoma. First of all, the argon laser trabeculoplasty. Argon laser trabeculoplasty (ALT) is well-known procedure to lower the IOP in various type of open-angle glaucoma by increased aqueous humor outflow through the trabecular measure. This technique was first described by Weiss and Witter in 1979 and has been reported to decrease IOP by 25 to 30%. The mechanism of action is first increase aqueous outflow by the expansion and the opening of the Schlemm's canal. Second is alteration of the extracellular matrix of the trabecular measure, and third is increase the cell division and increase the phagocytosis. The laser parameter is power is 300 to 1200 milliwatt, depending upon the reaction. Spot size is 50 micron. Duration is 0.1 second. Number of spot is 30 to 50 spot in 180 degree. The remaining 180 degree is treated subsequently or the same time as required. Initially, the mirror is gonioscope mirror is placed to 12 o'clock to the inferior angle view. The site of focus at the junction of the anterior non-pigmented and the posterior pigmented trabecular measure. An endpoint of the optical energy effect is blanching or tissue whitening with minimal or no bubble formation. The second is selective laser trabeculoplasty. The SLT is performed with the double and YAG laser. The frequency is 532 nanometer. It has replaced the argon laser trabeculoplasty due to the lack of the damage to the tympanic trabecular measure. The mode of action is it is selective target the melanin granule within the cell of the pigmented trabecular measure, and there is no structural photocoagulation damage to the TM. The laser parameter is 0.6 to 1 millijoule per pulse, and spot size is 400 micron. That's a big, and duration is 3 nanosecond. The number of spot is 30 to 50 spots over the 180 degree. In same as 180 degree is treated subsequently or at the same time. And the site of focus is the sort of entire covering of the trabecular measure, and endpoint is there is no endpoint like ALT. Now technique is same in ALT and SLT, but the main difference is the spot size. The consent is taken 1 drop of the anti-glaucoma medication, and then after the topical proparacaine is and after that Goldman 3 mirror reversal image, there is a 3 mirror 59 degree, 67 degree and 73 degree. The rich trabeculoplasty lens has 4 mirror. The 2 mirror at the 59 degree and 2 mirror is a 64 degree, and way to length of nanometer. In this picture we can show the ALT size is less and SLT size is 400 micrometer. So more size, full thickness trabecular, full thickness TM is involved in the SLT. The indication in both SLT and ALT is a primary open-angle glaucoma, inadequate control with the maximum medication management, with poor patient compliance and the prior choice of the filtration surgery. And secondary open-angle glaucoma include the pigmentary glaucoma, pseudoexfoliative syndrome, and juvenile glaucoma and angle recession glaucoma. The contraindication in both narrow angle, poor visibility, inflammatory glaucoma, neovascular glaucoma, congenital glaucoma, and failed previous procedure. The complication in both worsening of the POAG, transient corneal burn, iritis, peripheral anterior synegia, ifema, and trabecular hemorrhage. The pre-laser advice is all anti-glaucoma medication to be continued for the 3 weeks and control the inflammation by a topical steroid 4 times daily for the 7 days. And post-laser advice is control of the IOP raise, acute elevation of the IOP more than 10 mmHg in 10% patient after the 2 hours. And IOP check at first and third hour after the post-laser. The difference between the ALT and SLT is a type of laser. First, in ALT, Argon and double frequency and YAG laser. The second main is the spot size, 50 micrometer in ALT and 400 micrometer in SLT. And the pulse duration is 0.1 and 3 nanosecond. And other is endpoint is blanching and minimum or no bubble formation in ALT. There is no any endpoint in SLT. The site of focus is at junction between the pigmentary and non-pigmentary of TM, and SLT in entire height of the TM. All over is same in the ALT and SLT. One study there is in 2026 between difference between ALT and SLT in ALT maintaining IOP control in 67 to 80% of the eye in 1 year. After that 35 to 50% of 5 year and 5 to 30% for the 10 year. With SLT, IOP lowering occur within 1 to 2 weeks. IOP lowering can continue for up to the 4 to 6 months post treatment and also continue for 3 to 5 years with a similar iteration. There is one video.
Sensitive scar. The new
Now third is cyclophotocoagulation. Third is a cyclophotocoagulation. Cyclodestructive procedure are generally used for the refractory glaucoma or end stage of the glaucoma. The mechanism of action is transscleral cyclophotocoagulation (TCP) lower the IOP by destroying the ciliary epithelium and associated vasculature, leading to decrease the aqueous humor production. In vivo temperature of -60 to -80 degree at the scleral production. Temperature of -10 degree in ciliary process after 20 to 30 seconds of the application. The Nd:YAG laser is good scleral penetrating, and the light energy is absorbed by blood and pigment of the body. The contact method of TCP produce less scatter and thus the required less energy than the non-contact method. At least three mechanisms important for the lowering of the IOP. The first is inflammation. Second is decrease the aqueous production through the ablation of the pars plicata and increase the uveoscleral outflow. The current method of cycloablation is first contact transscleral diode Nd:YAG laser contact Nd:YAG laser diode. And third is a transscleral cyclocoagulation, and the fourth is a endo laser ablation in diode. The indication is the refractive primary angle closure glaucoma or open angle glaucoma, neovascular glaucoma, post-traumatic glaucoma, ophakic and pseudophakic glaucoma, especially in the ACIL, severe congenital glaucoma with the multiple failed surgery, post-penetrating keratoplastic glaucoma, and post-retinal detachment surgery glaucoma. Silicone oil induced glaucoma, inflammatory glaucoma, and glaucoma with severe conjunctival scarring, failed trabeculectomy and drainage implant, medical condition including invasive surgery, and patient refused to undergo invasive surgery. In transscleral photocoagulation Nd:YAG laser, laser system. In pulse laser system, very intense laser energy into the small area for a short period, and continuous it creates 1,000-fold greater energy than the use for the routine photo disruption. It may contact or non-contact. In non-contact method, employ the 8 joule for the 20 millisecond and 30 to 40 spot over the 360 degree. Probe is placed 1.5 technique for being applied over the 0.52 mm posterior. The chance of the persistent hypotonia are greater with the Nd:YAG laser. No, distance, not place, like distance from the limbus. Second is a transscleral cyclocoagulation with diode laser. It is a better alternative to the Nd:YAG laser. The diode laser is 810 nanometer, has better absorption by the pigmented tissue of ciliary body, requiring lesser energy per spot. Contact method is superior as it is advantages of reduced scarring and the increased scleral transmission. In non-contact method, energy is 1.2 volt and contact 1.5, and the duration is non-contact is 990 millisecond and 2 second in contact, and spot size is equally same 40 spots and 25 to 30 spots, and circumference is 360 degree in both. In complication, the conjunctival burn with mild post-operative inflammation and atonic pupil. Uncommonly, there is severe uveitis and loss of vision, and rarely IV and thysis prescribed. The variability in the clinical response to DLCP stems from the following facts. variability in the pressure exerted over the sclera, difference in scleral thickness, and variation in probe inclination. And the third is endoscopic cyclophotocoagulation. The ciliary body can be treated directly within the eye using the argon laser light delivery through a 20 gauge fiber optic probe placed through a pars plana port. Use 5 lux video camera and give a 70-degree field of view. Focal distance from the laser is 0.75 mm. Done with argon or diode laser. In limbal approach, the cyclophotocoagulation is done through a temporal and nasal limbal entry for nasal 180 and temporal 180. The advantages is decreased energy requirement, inflammation, and collateral tissue damage, and the surgeon can able to ciliary process under direct visualization.
There is no sound.
So, sir, in video no sound. There is only music, sir.
Okay. You can speak about it then. What exactly is being done?
This is a combined effect of the CCB. The entry from the side port through the temporal and nasally 180-degree, and the endoscopic probe is to insert in the anterior chamber, and first before that the iris bomb is created by the visco, and and after that the ciliary process destruction by the probe, and treat with the maximum 240 degree 240 to 360 degree of the ciliary process. The fourth is a transvitreal cyclophotocoagulation. The procedure is performed after the direct visualization of the ciliary process through an operating microscope after the scleral depression. It requires a clear media, and the patient should be having aphakic or pseudophakic. The transpupillary cyclophotocoagulation in patients who have visible ciliary process, it is sometimes possible to deliver argon laser energy directly to the anterior surface of the ciliary process. The transpupillary cyclophotocoagulation can either be performed using the argon green or the frequency double ND laser. The post-operative management at the end of the procedure, the subconjunctival corticosteroid to be applied. The pre-operative anti-glaucoma medication are continued. Sometimes very strong analgesic is required, and at the time one may have to use narcotic analgesia. For follow up at 1 hour, 1 day, 1 week, and 1 month. Then according to the response. The complication, this procedure is converting into the malignant glaucoma, macular edema, retinal detachment can be happen. Intraocular hemorrhage, best corrected vision loss, and sympathetic ophthalmitis. The treatment failure also be included. The marked pain, mild to severe iritis, synechia formation, the transient rise of the IOP, hypotonic, phthisis bulbi, lens and zonular damage, pupillary distortion, and corneal graphite, and scleral thinning and staphyloma. The second is Argon and ND-YAG laser iridotomy. With argon laser, continuous wave or pulse argon laser may be used to create an iridotomy. The long pulse in 0.2 second for light color iris, like blue, hazel, and light brown. The short pulse is 0.02 to 0.05 second for the dark brown iris. The power is 1000 milliwatt and the spot size is 50 micrometer. Single area is treated with superimposed application until perforation is obtained. The pigment film is found to move forward. That's like smoke sign and waterfall sign. In with ND-YAG laser, the iridotomy is replace argon laser due to the superior efficacy, reliability, and faster perforation. The energy is 3 to 8 millijoule per shot from Q switch ND-YAG laser, and 1 to 3 shots are sufficient to complete the procedure. A full thickness opening in iris in one shot is the optimal target. If the anterior chamber is depth is nil, the pulse should not be exceed more than 10 to 12 millijoule. The endpoint is sudden melanotic pigments from the posterior to anterior chamber, sudden deepening of the anterior chamber, and red reflex in slit lamp to in retro illumination. In general step, explain the procedure to patient, sign the informed consent, the pilocarpine 2% before the 1 hour procedure, anti-glaucoma medication to be continued, improvement of the corneal clarity. If not, then the application of the glycerol or sodium chloride, the topical anesthesia and steady fixation. The patient should be asked to avoid the loop temporally and nasally to avoid the macular damage. In appropriate laser contact lens, the Braham iridectomy lens, this is a 66 diopter plano-convex peripheral button over a routine contact lens, or a Pollack iridotomy. There is 2 buttons. One large button is for the iridectomy and a small for the gonioscopy. And the indication is prophylactic iridotomy in fellow eye with history of primary angle closure glaucoma. Pupillary block in aphakia and pseudophakia or subluxated. Iris Bombay, combined mechanism with PSEG and open angle in malignant glaucoma, and acute and chronic angle glaucoma after the terminate the attack. The contraindication is occluded angle more than 60, chronic inflammation and hazy anterior chamber, that's absolute contraindication, and flat anterior chamber, corneal opacity, and NVI is a relative contraindication. Optimal size of the iridotomy, supranasal quadrant is preferred because between 10 to 2 o'clock, and it will cover the upper eyelid. Avoid the 2 o'clock position. A single gas bubble may collect here, and iris strip of fuse are easy to perforate, and pigmented furuncle on the iris might be absorbed more laser. Only in aphakic with silicone oil or silicone oil in posterior chamber, the iridectomy should be done in the inferior part. The post-laser advice is meiosis, 2% pilocarpine TDS for the 7 days. Cycloplegic and mydriasis also be given. The control the inflammation to for the topical steroid, and control the IOP to continue the HEM for the 3 weeks. The complication is uveitis, pigmentary dispersion syndrome, hemorrhage, elevated IOP, damage to the lens and anterior capsule of the lens, and formation of the cataract and corneal burn. And the argon laser versus ND-YAG laser, the uptake energy required to pigmented cell in argon laser and does not require in ND-YAG laser. The iris color dark brown in argon laser, and the light or medium color in ND-YAG laser. High chance closure in argon laser, and ND-YAG laser is less chance to let closure. The combination of argon and ND-YAG laser technique. using sequentially combination for the dark brown iris or for the patient who are on chronic anticoagulant therapy. First, the argon laser salt pulse mode in use the attenuate the iris to about 1/4 of original thickness and to coagulate vessel in the area. After that, the YAG laser is used with beam focus at the center of the crater. One or more bursts are used to complete the full thickness of iridum. The second is laser peripheral iridoplasty. It is procedure to deepen the angle of the anterior chamber by replacement of the argon laser burn in the peripheral iris to stretch the tissue between angle and site of the burn. In technique, parameter is energy is 200 to 500 milliwatt, exposure is 0.2 to 0.5 second, and spot size is 200 to 500 micron. If contraction fail, the energy and exposure is increased. The number of laser in each quadrant is 8 to 12 burn, and the contraction effect is visible immediately by deepening of the anterior chamber. The site of focus is laser is focused directly on the most visible iris peripherally. The indication is medically uncontrolled angle closure glaucoma to open the appositional close angle and to facilitate the ALT, SLT, and shallow anterior chamber and plateau iris syndrome. And contraindication is flat anterior chamber, extensive corneal opacity, and angle closure associated with the extensive peripheral anterior signage. The post-laser advice is topical steroid, topical anti-glaucoma medication, and complication is transient IOP raise, corneal burn, and pupillary distortion, and iris atrophy. The argon laser pupilloplasty, but there is no in use in the glaucoma, but I include just the pupilloplasty is technique alter the size, shape, and location in eccentric or irregular pupil. The indication in myotic rigid pupil resist to pharmacological dilatation, pupillary block, glaucoma in ophakic and pseudophakic chronic myotic therapy to facilitate the examination and treatment of the posterior segment disease. And all steps are same the general examination except the mydriatic drop 1% tropicamide is put in the eye. The photomydriasis technique is initially placement of the 360 continuous concentric small contraction argon laser burn just adjacent to the pupillary margin. After that, the 500 micron 0.2 to 0.5 second and 400 to 500 milliwatt laser burn consequently just outside, and the initial laser shot in the single or double row. Post laser advice is same topical steroid control IOP and discontinue myotic for the few days. And complication is the transient IOP rise, iris atrophy, and transient iritis. And YAG photomydriasis is also the indication of the ophakic eye with the rigid pupil, ophakic with the iridoid synecdoche, and ophakic eye on myotic therapy for long period, failure to argon laser photomydriasis, and contraindication is eye with the acute uveitis and eye with uncontrolled glaucoma. In this picture, the in this picture, the first adjuvant to the peripheral iridectomy is 12 o'clock to enlarge it, and subsequent short to are toward the pupillary margin to complete the radial iridotomy. Laser shot are applied at the junction of the pupil and the hyaloid interface after the site anterior defocusing. The post-laser advice is mydriasis, 1% tropicamide TDS, and control the inflammation and IOP. And complication is pigmentary dispersion syndrome and microhemorrhage. And last is NDA chorioplasty. The chorioplasty is a procedure of the centering of ectopic pupil by alternating shape or enlargement of the pupil. YAG laser is preferred over the Argon laser for the chorioplasty due to its greater efficacy. The indication is enlargement of the pupil for the improvement of the vision, optical iridectomy to improve the vision in eye with the decentered IOL or central corneal opacity. The technique is the argon laser coagulation is done only in presence of the visible blood vessel on the iris surface at the proposed area of NDR chorioplasty to prevent the hyphema. On an average, 8 to 9 millijoule energy is required per shot from Q-switch NDR laser. And splinter is the truest area to cut the NDR. And collateral is most prone to hemorrhage due to presence of the minor arterial circle of the iris. The procedure is started in the peripheral part of the iris trauma by making full thickness hole in the iris. There is a same picture. The first is the procedure is start from the peripheral iris trauma. The second and third is successive cut in the iris are made toward the collateral and the iris sphincter. The fourth picture is the collateral sphincter and the pupillary margin is cut toward the end to delay the occurrence hemorrhage as far as possible. Complication is transient raise of IOP, hyphema, and pigmentary dispersion syndrome and cataract formation.
So, so the most common laser that is YAG. So the end YAG yes.
So
So
that
we take 7 and then 7 now. There is one more that we normally do. Red reflex we can't identify immediately. We have a red. We are doing with lens or without lens. You are not getting illumination when you are doing the laser. It's time for it for that. Any yeah, that is what I guess gush is the sure short sign that we need to get that to it. Sudden deepening does not happen in normal PIs that we do unless it's iris form. Iris form play instantly. It's not that. Yes. Combination of Argon laser and YAG laser. It's definitely given in the scientific form. Because Argon laser is majorly followed on eastern side. So even ALT and SLT, I think then eyes cannot take it. And I'm the study is also doing it in Indian eyes. Somehow it has lacked the popularity in India. ALT and SLT. But ALT, I think lightly pigmented eyes is good for NDR. But then Argon laser is good for the dark. Since NDR when they started, I think on the western side they found it easier and dark eyes, you're not. That's why they got it theoretically. But still we are able to do it with multiple shots. Maximum shots that I have taken, the thickest iris was up to 40. 30 to 40 shots, but we have to give an interval. You can't do it on the same day. That can cause inflammation. There was one patient I had to call for next week. Not very even after shots, and there was enough inflammation. So we do it on a second day, and it definitely at the same spot. So India done on 2 different days also. So the purpose.
Right.
This is yeah.
So these are long again. After how long?
We normally call the patient for 1 week, and for all PIs, we have to explain them there are chances that it can get blocked when we are doing it. Otherwise, the patient might not be very confident. If we have a chance them again, second, they feel it's they. So we have to try out that it might get blocked some treatments. So we might have to reach the next one. That's why we are calling it. But I
And then what point so I spoke on
silicone oil, I think we do it here. Well, any reason?
issue.
Yeah, silicone
Oil
oil,
is
it
lighter.
tends to come into the AC, it tends to block the PI.
Well, it's also be
Whenever it gets emulsified, it needs to come into the AC. So, yeah. There's a name to that inferior PI.
Windows.
And I have no experience with this with plastics. There are other indications in glaucoma. One thing is we do laser suture lysis, especially in advanced glaucoma, where we want strict titration. Don't want time of 3 weeks or 6 weeks. We suture the flap. Then we release one suture and laser suture lysis that we can. And I stop. I think malignant glaucoma, when we disturb the anterior hyaloid, we come across post-operative shallows and shape. Confirm is malignant. So, can have it. Shallow is definitely combined with high unless proved otherwise it is malignant. Whenever you see shallow is essentially shallow. It's not just the very has to be iridotomy touch or just short of touching the
Can't dilate.
undilated. And it's very successful. In that case, we see the image of C. To undilated, you just have to retrolenticular, you just have to take the
So that you have to give managed. So dilate.
can, I think patient will have pain, give manage. We won't operate with management. Generally, that stage. I mean, you form a place. What is exactly happening? Stimulated emission. There is spontaneous emission of radiation whenever these atoms, electrons in the atom, they come back from an excited state. I think. The excited state of electrons is not very stable, so they don't want to stay there. When they come back to the state, they emit radiation. This is spontaneous. But here we are stimulating them by giving excessive power, like external. They are actually pushed into the excited state by giving the photons, extra photons, and then they come back and that is they release the radiation. Why does see when we do IRIDOTOMY pupillary there's no bleeding. There is bleeding. Yeah. Yeah. It's photo disruption. Even when we are snipping off the iris with the scissors, we are crushing the blood vessels. The iris. So it is not allowed to bleed. With laser, we are actually hitting a spot on the wall of the vessel. So it's just opening up the vessel.
surgical PI. The exact site where the root of
Especially in traffic, the pupil and cleostomy BSP. It should not be a very large PI. They can sometimes be other BTS. And in opaque eyes, we have BTS. Cases. It's just peripheral eyes.
Okay, Kishan, done?
Yes,
Yes.
sir.
Yes, okay, good. So go back to the slide of laser PI. Okay, well, when do you use argon? Or we don't use argon, so I think you are still using the old term. So in nowadays, I find it's not useful to use the term argon laser because we don't use argon laser. What laser we use?
NDR laser, sir.
It's a double frequency
Double.
Nd:YAG laser.
Double.
Okay, so don't now in future never use the term argon laser. It's historical only. Okay, go back to the previous slide. So when do you use the double frequency Nd:YAG laser and when do you use the Nd:YAG laser for iridotomy? Do we have both in our center?
Yes. Yes, sir.
Okay, so double frequency Nd:YAG laser is the green laser.
Yes.
And what is the color of Nd:YAG laser?
No colors.
Yeah, colorless. Okay, so when do you use Nd:YAG laser and when do you use double frequency Nd:YAG laser or green laser for iridotomy? Okay, anyone? Normally, what is used?
Double it.
No, we don't use double frequency. We use the Nd:YAG laser
Yes.
for iridotomy. Okay, and it's a photodisruptive laser. That is what is commonly used. Only in cases where this fails because the iris is too thick, or if there are presence of say neovascularization in that area, then in such cases we can use double frequency Nd:YAG laser. So what that does is that it thins out the iris in that area, and then you can again either use Nd:YAG itself or you can use the green laser itself to make a opening in the iris. Okay, so that can be used in case this is not able to make the opening. Okay, so
Yes.
what is the commonly used settings? You have written 1000. No, that is green laser. I
This
think
is
you have
8 millijoules, sir.
3 to 8.
3
Okay,
to
so
8. 3 to.
yeah, so generally for most of the PI cases, you can use the lowest energy which is available. Because if you use higher energy, there will be more disruption. So start with the lowest energy. Do we use offset in this case? What is the offset? You have seen the
Zero.
YAG laser, no?
Yes, sir.
Okay, so what are the offsets which are available? Anyone? Hmm? Yes.
And 125 and 50 or 150.
So we have anterior as well as posterior offsets which are available. So what basically it means is that wherever the aiming beam is, the actual laser will be fired posteriorly if we are using posterior offset. And you can also change the offset also in microns. Okay, you can have 150, whatever 300 microns. So it's, or it can be 125 in front anterior offset. Okay. So in for YAG PI, we don't use offset. That means wherever the aiming beam is there, at the same place, the laser will be fired. Okay. For YAG capsulotomy, we use the posterior offset. That means when we focus on the posterior capsule, the laser will be fired behind that posteriorly. So we don't get the lens pitting because of that. Okay. So here we don't use the offset. So if you are using posterior offset and trying to do PI, then you may not have adequate power delivery at the iris plane. Okay. And always look for the thinnest area of the iris. So generally with lowest energy also you can get a good YAG PI if you choose the spot correctly. Okay. Make sure that pupil is nicely constricted. More the constricted pupil is, more thinned out will be the peripheral area of the iris, and then it will open up the iris more easily. Okay.
Yes.
That you have to understand. Okay. So if in first go PI is not possible, which may rarely occur, call the patient again after 2-3 days or more, maybe 1 week. By that time the iris thins out in that area, and then it is easier to create opening in that area. Okay, any other questions? Okay, you have talked about the YAG PI lens also, na, iridotomy lens.
Grams.
Then what is the advantage of lens?
Stabilize the globe, and supposing there is any bleeding, we can give compression.
Yeah, and most importantly, it has a convex lens area. So what the laser is, what it does is that it focuses the laser beam on the iris, but on the corneal area it is wide apart, that laser beam. So sometimes when you don't use the lens, you may have corneal pitting, or corneal laser will be fired on the cornea, which may lead to some collagen damage in that area. So makes it white for some time, brief period. So visibility may be lost. So here chances of corneal laser is less, and the energy will be more focused on the iris. So you need very less energy to do the YAG PI. If you are not using lens, at that time also you should be able to stop the bleed by just pressing the globe. You have to keep the pressing on the globe for at least 2 minutes. That is what is the bleeding time, right? So by that time, usually the clot forms and the bleeding stops. Okay. In case of emergency or otherwise, antiplatelets are okay if you are going to do YAG PI. If you want to wait, you can wait for 3 to 5 days after stopping antiplatelets. But definitely, if patient is on anticoagulant, like say warfarin or other its equivalents, then it's must that you should stop for a week and then do YAG PI, because antiplatelet agents do not have any issues with the clotting, but anticoagulants will not allow clotting to occur. So you may have, more bleed after doing PI. So make sure you take proper history of the patient and checks, and don't write anticoagulants and antiplatelets are different and anticoagulants are different. So use the proper, what drugs patient is on, you should know before you are doing any procedure. Okay.
Okay. Yes.
Yes. Any other comment, Josna?
Indication of YAG PI when there is cataract. When there
In
is
case of
early
cataract.
and angle closure patient with early cataract, instead of going for YAG PI, we should directly go for early cataract extraction.
Yes. Why?
Supported by the Eagle study, it
Correct.
proves that early lens extraction is the way to go instead of going for PI. That actually opens up the angles and relieves the pupillary block.
So in case of angle closure suspect, when we do PI, what is the percentage of patient who will still go into chronic angle closure? Taken any study?
Yeah, there is a study. I think 10 to 20% can still go. 80% of them are converted. They do not go for chronic angle closure.
I think it's even higher. I think it's 35%, 35 to 40%. So, and that's because even after making the PI, the lens continues to grow and pushes the iris forward. So peripheral iris may still start closing, and patient can. So PI is not 100% treatment for angle closure. Okay. But definitely cataract surgery or clear lens extraction definitely deepens the anterior chamber and deepens the angles, widens the angle. So chances of angle closure after that are very, very less.
Yes.
Okay. So generally, and yeah, Kishan, you are doing the triaging in the OPD. So how do you check for the anterior chamber depth?
Sir, when Eric, sir, VH
VH and
and torchlight examination, sir.
yeah. So on torchlight, if you feel that angle is very shallow, then there is no need to dilate. And otherwise, if you feel on torchlight that the angle is shallow, then better to get the anterior chamber depth done. If it is too shallow, then better it should be seen by the consultant. Maybe patient may be advised a YAG PI before undergoing dilatation. So generally, is there any Josna cutoff for the anterior chamber depth where you should avoid dilatation?
Grade 2 we normally avoid, sir. Grade 1 and 2. We avoid dilatation before doing gonioscopy.
Okay, and about this thing,
Above 2, we can dilate,
AC
sir.
depth, AC depth.
So below 2.5 is generally don't.
Yeah.
0.5.
Below
2.5 mm.
2.5. Okay. Just try to read if there is any guideline for anterior chamber depth and dilatation.
Oh.
Okay. Yes.
Yes.
Okay. Thank you. We'll end the meeting.
Thank you, sir.